Welcome back from the break. Please find yourself a seat. We have another wonderful panel coming up. I'm Marian Mulkey. I know many of you, but many of you are new to me, and I'm delighted to see you all. I should have been here to introduce the last panel, but my train didn't agree with me, so here I am now. I have the privilege of chairing the ITUP Board of Directors, and I'm also acting right now as its interim executive director. Quick word of thanks to our phenomenal staff who pulled this all together today and will continue to do a really great job as the day goes on. There's a lot of logistics and content and thinking that goes into these events, and they do a first-class job. It is my pleasure to turn to our second panel of this pre-conference and to introduce to you Melora Simon, who is going to kick off our panel on local perspectives, calaim on the ground. Melora is our moderator, and she is Associate Director at the California Healthcare Foundation. In that leadership role, she works to advance effectiveness and impact within the AIM program and other transformational Medi-Cal initiatives. Prior to joining CHCF, Melora worked as an independent consultant, providing strategic planning and other support to healthcare organizations, and previously held positions with the Pacific Business Group on Health, Health Plan of San Mateo, Stanford Clinical Excellence Research Center, and McKinsey & Company. Melora and panel, we're so glad to have you.
Thanks so much, Marian. For those of you that don't know us, the California Healthcare Foundation is an independent nonprofit foundation that works to improve healthcare for all Californians. And we're particularly focused on Californians that are not served well by the current system and Californians with low incomes. And so as a result, we're watching calaim very, very closely. We've set up a resource center to help people understand its potential. And we're doing a lot of grant making to support it and to support listening and learning from it. So before we get into the panel, we thought it would be really helpful to ground the conversation in the perspective of one of the people that calaim is trying to help. So without further ado, if we can tee up the video and hear Rosalind's story.
My name is Rosalind Evans. I was born in 1959 and I was born in Los Angeles, California. When I was 12, my mom had me admitted into mental health inpatient because I tried to slash my wrist in a restroom because the fighting was going on in the house. I was told I was bipolar. I really didn't understand what it was meant. My mom didn't really follow up on it. My people didn't believe in that. They didn't believe in this mental illness stuff. I get the medicine, throw it away, go back with my normal life. And then I found alcohol. That became my medicine. It started off as fun because I could get up and dance and I could fit in a crowd and, but it slowly turned into nightmare. I am a miracle. I am lucky to be alive because when I don't take my meds and when I drink, I can wind up anywhere. I can wind up in anybody's house. I have put myself in very dangerous situations. When you're homeless and you don't have anywhere to live and you're mentally ill and it's hard to find proper treatment. I felt like a person, just a piece of trash just being thrown away and kicked out of hospitals. They give you some medication and you're sent on your way with nowhere to go, nobody to turn to that understands you. The breakthrough for me was when I got housing, assigned a case manager, a therapist, a psychiatrist, a substance abuse counselor, a team that came together to give me support. And I didn't have that for years. When I relapsed emotionally, I will stop taking my medicine. And once I stopped taking my medicine, then comes the drink. Forget the medicine, it's all alcohol. My mom is dead. I don't have any brothers and sisters. I'm an only child. My children are all in another state. I did not raise them. So my caregiver steps in and encourages me. Rosalind, did you take your medicine today? When I get on those lows, Rosalind, you have a doctor's appointment. It's important that you see the doctor. That's played an important role in my life. My diagnosis is bipolar disorder. It's a chemical imbalance in the brain. I'm not in denial anymore. And it's led me to where I'm at now. it's a lifelong thing. It's not something you get your medicine and okay, I don't need to see you no more. For my life, I will stay in treatment.
So I think that sets the stage for how important calaim is. And we just heard from our policy panel about all the new changes, but we thought it was really important to take a step back and hear about how it's been going the first year. And we have a really great panel to help us understand that. We have Shamsher, who is the Associate Professor of Emergency Medicine at Harbor UCLA and is also a consultant for the Department of Health Services in LA, focused on the reentry population. Next to him, we've got Ryan, who's the Behavioral Health Director in Sacramento County, Pooja, the co-CEO of the Illumination Foundation, and then finally Anwar, who's the VP of Long-Term Services and Supports at the Partners in Care Foundation. So I thought it would be helpful to just start with a lightning round, asking each panelist what the one thing that they're hopeful about as we go into year 2 of calaim. So I'll start. And for me, I'm hopeful about something that we actually don't hear very much about, which is calaim's work to improve medical health for everyone through the Population Health Management Program. I'm sure, what about you?
Yeah, there's a particular focus on the population impacted by the carceral system, continuing to build the network of community-based care that kind of walks hand in hand with criminal justice reforms that are happening and kind of building carceral alternatives.
What am I hopeful for? I'm hopeful for all of these. You just heard Michelle Cabrera talk about all the different behavioral health initiatives that are all hitting at the same time. I'm hopeful that we'll get them all taken care of and tied up in a bow so that we can get away from this chaos and make sure we continue to serve those that we're serving.
Yeah, and at Illumination Foundation, we serve the unhoused and people experiencing homelessness. So one of the things that I'm really looking forward to is having all our clients get access to the ECM benefit. It's a great benefit, but for our population, it has not been easy to access because some of those services are still living with the MCPs and our clients aren't able to figure out how to get to them. So I'm really hoping it's a great benefit. In one of our counties, we're doing that and it's really been wonderful. So I'm hoping that we can do that for all our counties. And the other thing is the recuperative care, the medical respite benefit. Again, one of the counties, the criteria is very tight. Clients who really need it aren't able to get it. So we're really hoping we can tap into some of that resources as well.
What am I hopeful for? I think we've had a nice long year to experience calaim, and I'm hopeful to be able to fine tune it, address quality and equity through data exchange, enhancing the care coordination. And that goes beyond the managed care health plans. That's with the skilled nursing facilities, that's with the hospitals, that's with other CBOs.
Thanks very much. We heard a lot about managed care just in that lightning round. And one aspect of calaim is that it does give managed care a bunch of new responsibilities. So Anwar, your organization has a really deep and long experience working with managed care. How has it been implementing calaim in this first year?
Well, first and foremost, I can't tell you how fun it is to work with the managed care. We've been working with managed care health plans for many years, and they've always been our lifeline in helping us enhance the services that we provide. Because if we're successful, they're successful, and if they're successful and we're successful, then the whole community is successful. So together, it's been quite a pleasure working with them.
Go ahead, Pooja.
Yeah, so prior to calaim, we were working with the whole person care program and with one of the health plans. So we had a little bit of an experience getting ready on how to work with MCPs. And I think that really helped us because as soon as calaim hit, we had to contract with 4 counties, several different health plans. And I think the experience that we had working in the whole person care program with health homes really helped us. But to be quite honest, working with the different MCPs, they each have different ways of running the programming. It has been quite an interesting journey. And the key thing is that there has been open dialogue with all the MCPs. We have weekly check-ins and we continue to work through some of those barriers. But for a community-based organization, the focus is really taking care of the clients. And we're now having to spend a lot of time meeting the administrative side of calaim, which we understand is required. So we really needed to spend a lot of time with our staff, training them, getting used to this managed care plan world, which we were not used to. And that continues to be an ongoing focus for us.
Do either of you have something to add?
Well, in terms of our relationship with managed care, Sacramento County, we have 5 large health plans. And so it's a complex terrain for our consumers as well as for anybody working with our health plans. Sacramento County, we identified early on that we were going to work with the special population of those with SMI SUD in order to help support them with their enhanced care management needs. And so we already have contract providers that are serving this population. So just made a lot of sense that that consumers would continue to have just one provider that they were going to in order to receive their enhanced care management as well as their behavioral health care. So we had a really great process working with those 5 managed care plans. They were great partners and came together and identified as many different ways that we could standardize across the 5 different health plans in order to identify how we were going to implement this in Sacramento County. And so working towards that and still excited about making sure that we continue to improve it and continue to fine tune and get some of the kinks worked out.
Yeah, I'd say from my perspective, LA County, just folks may not know that for the carceral system impacted population went live to some extent starting last year, at least in the community facing side, not on the jail-based side. And this is the first time in some ways that the managed care plans are working with folks, thinking about folks while they're incarcerated. And it was also a little bit of a difference for Department of Health Services, where Department of Health Services runs correctional help and under whole person care had contract with community-based providers who would serve individuals post-release. So it's a change on both sides. And I think there's some discontinuities that we're trying to work through as we're moving forward. And it may be useful for kind of folks to hear. And I think some of the challenges is just the data sharing element, right? So for this population of focus, being incarcerated is one of the critical elements that make folks eligible. And because the bar to entry is lower in this population of focus than others, it's critical that that information gets relayed. On the pre-release side, we're unable to submit referrals because the person's Medi-Cal suspended or inactive. And then on the community-facing side, people oftentimes, rightfully so, don't want to divulge that I just came out of jail. So that there's a huge potential for missing out on ECM referrals for this population. The other thing that we've been working through with the managed care plans very closely is our provider network. And this came up in the previous panel discussion. We know that, this is a population that's been stigmatized. They have a lot of distrust for the network of providers that are out there. So it's critical for us to understand as new contractors are being pulled into this ECM network to serve this population, what is their level of comfort? What is their understanding of pre-release processes? What is their understanding of probation, parole? Are they trauma informed? Do they have folks with lived experience? And more so than that, are they aligned in this idea of not just kind of mitigating the harms of incarceration, but have more of a structural understanding of the carceral system and can be aligned in kind of what I mentioned earlier, kind of criminal legal reforms that are happening countywide. And then the last piece is kind of data. There's a discontinuity that happens between folks who are incarcerated and potential referral being made. And when someone who, lands on the ECM rolls, essentially, for lack of a better term, because we know there's a huge loss to follow up in between. And our goal in working with managed care plans is to really center that population that we know historically hasn't been served well by our systems of care. So the folks who are ending up in crisis mental health services, the folks that are ending up reincarcerated, the folks that are having overdoses, dying, ending up in emergency department. So how do we capture that entire spectrum of referral, pre-release, all the way to folks being engaged and adjust it based off of the folks that are listening? So.
You talked about one of the many barriers to access. And And interestingly, in late December, the Department of Healthcare Services released some early numbers on the Enhanced Care Management Program, which showed that about 68,000 people were enrolled in ECM as of June of last year. However, the bulk of those enrollees transitioned from whole person care and from health homes. So it only is about 12,000 new enrollees. And to put that in context, in their first 6 months, both whole person care and health homes did about double that. I'll turn this over to any of the panelists. Why do you think enhanced care management has gotten off to a slow start?
From Sacramento County perspective, like I mentioned, we have the 5 health plans. And we had to go through our county processes to develop contracts with the health plans. We had to go through our county process for developing contracts with the contract providers. We also had to develop a lot of workflows around how we would identify individuals who were eligible for enhanced care management. And then ultimately we needed to make sure that we were coordinating authorizations with our contract providers. And that's an area where we've had some definite challenges regarding coordinating authorizations across all 5. There's actually, I've been misspeaking. 4 out of our 5 contract managed care plans have agreed to work with us around enhanced care management, Kaiser being the one that they're doing it in-house. So it's really 4 that we're working. So for the 4, the challenge has been getting our contracts for our providers, get them to staff up when this is a fee-for-service, framework. And so they have to hire somebody, get them trained up before they actually start receiving revenue. It's not fee-for-service. It's a per member per month sort of but either way, you have to get the money after you start doing the work. So they have to get people up and hired, and that they see that as risk, right? They have to hire somebody before they are sure about getting the revenue. And then we did run into some challenges with our various health plans regarding getting those authorizations. And so working out some of those kinks. And then in the hindsight, I do think that for our actual contract providers doing the work, this is going to be helpful for them in the long run, because the county is the one that's navigating the different managed care plans, figuring out the different processes, making sure that the kinks are getting worked out, rather than having each one of our contract providers have to figure it out on their own, working with each of the 4 different health plans. So I do think it's going to be a benefit that we sort of stepped in to have that be that sort of a mediator type of a role. I think that's one. So honestly, we got some of our first authorizations. I don't want to misspeak, but it's been very recently, within the last 30 or so days.
So we're in 4 different counties, and only one of the counties, we as a CBO are actually doing enhanced care management. So one of the reasons, our clients aren't able to access this benefit is because at the MCP level, that benefit is kept in-house. And as we know, with this population, there needs to be a lot more outreach and trust building. So I feel one of those reasons that our clients aren't able to get the access is because they're not really coming, meeting the folks that they're used to meeting, who's explaining what enhanced care management is and why that benefit matters. A lot of times, there are phone calls, messages left for our clients don't have phones. So our team is out there trying to meet clients in the field. So if as a CBO, we were allowed to deliver that benefit, I think we'd have a lot more clients enrolled in ECM. Although I'm hearing from DHCS that is definitely, going to be changing over the next 6 months. So partly I think the low enrollment is because the folks who really need it, we're not able to find them, So what can we do to actually find the clients who really need the benefit?
Yeah, and I have a similar experience. I feel like Partners in Care has been working with the managed care health plans and medical groups and hospitals. And we've also been part of the health homes pilot program. So we were lucky enough to gain some IPP funding to scale up in preparation for calaim. One of the reasons why I think it went slow is because I don't really think that the state of California received any a lot of outreach from the state or even from some of the health plans. We've noticed that Partners in Care was really out there trying to explain calaim enhanced care management community supports to hospitals and medical groups. We've asked the state to do more outreach and education to the community, but there was a lot of priorities going on. And we couldn't really do that much. I mean, COVID was happening, first of all, still kind of is. But there was other implementations of the whole person care transition. So it was a really difficult time. And what it really caused, and I think the earlier panel mentioned this as well, is we scaled up. We had a hard time looking for a solid workforce. And now it kind of slowed down. So it's like, where's the volume? We don't have the volume. We need to kind of survive here. And we cannot just have care managers with a caseload of 15. So historically, we had the State Department of Healthcare Services through the Health Homes program provide us with the TEL, the actual referrals members identified, and that would go to the health plans. The health plans will clean it up and then send it over to us. We're talking about thousands of referrals, so many referrals that we could not even handle it. So we kind of anticipated the same thing with calaim, but we have not seen that yet. So we're kind of at that point where not only partners, but our contracted subcontractors, we have a community care hub that we subcontract with multiple community-based organizations so that we can have that equity and that specialty in that community. And now that we signed them up, we can't seem to give them the volume that we expected.
Yeah, I'll just add for folks, the kind of population of focus impacted by the carceral system, that a lot of it has to do with what I mentioned earlier, just in terms of that separation of information regarding carceral history and the ECM referral itself. Another element of it is interruptions in Medi-Cal that we're all, many people are familiar with as folks move through carceral systems. And in particular, in this period of time we're in right now, even if there's prompt reactivation or unsuspension of someone's Medi-Cal at the time of release, there's going to be a gap between that time and when they're enrolled in ECM. And we all know that, that initial reentry period is a period of extreme vulnerability. So we can't, just wait until someone connects with ECM. There needs to be something that happens in between. So I think in some ways we rely on the systems of care and the accompaniment that we had built through whole person care until we kind of figure out those things to make sure that we don't lose touch with someone for 3, 4, 5, 6 weeks. Hopefully, as we move to the 90-day, pre-release window where we can activate Medi-Cal early, at least in limited forms, we kind of obviate that issue. And I think the one other thing that it's kind of related to that as well, I think it's about relationship building with new providers who are coming on. Again, from the positionality of a pre-release provider, someone has complex needs, they have behavioral health needs, they might need an appointment with their primary care physician and this other thing. So now we have an enhanced care management provider we know that has the ability to do all these amazing things, but maybe that relationship's not there yet. And there's this risk of giving 5 referrals to the person, and the person may show up at one of those or a couple of those and not get the service they want or not have their needs fulfilled, and kind of burn that bridge. So it's being really mindful about how do we coordinate the referrals that we're making from the pre-release management.
I think each of you works in an environment where there are multiple plans. And one of the things it's tricky to get right is the balance of standardization and flexibility. You've talked a bit about standardization in Sacramento, for example. Where do you see opportunity for innovation around the flexibility, and where do you see the biggest need for standardization?
Okay, so standardization goes across the whole bit of it, right? So starting off, and then, so let's just acknowledge the parts that we can't standardize. That's that we can't have conversations around rates. That's a confidential conversation that's had privately with each of the different plans. So just acknowledge that right up front. And then there are the places where we are seeing some standardization is regarding the criteria that are being used in order to identify who's going to be eligible for enhanced care management. We have work group that regularly meets to discuss any other areas that we can identify for standardization. And the area where we're identifying some challenges is around authorizations, where each plan has a different set of instructions for how to submit a request for authorization and then receive that authorization. And I think we're doing better on the billing side, but it is a little bit different, but I think we're getting pretty good at getting that as standardized as possible.
I could go. I think one of our maybe opportunities, that's the right word, is to really try to look at the standard model of care. I see a lot of ECM providers really providing different services and coding. The encounter data that they are coding are translated differently in my world than it is in their world. So maybe coming up with some sort of standard model of care, standardizing the assessment process or the actual assessment care planning, I think is huge. I see a lot of different assessments and care plans out there that capture different data elements. And for me, being in care management since the late 90s, dating myself, is scary to see that so many people are assessing our communities in different ways. And I think lastly is really the standard data sharing platform. And I'm really hopeful that the California data exchange platform will really help us resolve that.
Yeah, and I think again, just standardizing the assessment for ECM would be really, really helpful, because when you're working with different MCPs, different counties, trying to really focus more on the client and minimize as much as we can the documentation, the standard template for the assessment and care planning would really, really help.
Long as you make the one thing I'd want to safeguard against is we already have to do an assessment for behavioral health as a part of our other services. So we don't want to have to add on a second assessment. We'd probably want to make sure that we were covering our bases with our existing assessment.
That's a good
Make
point.
sure we're not duplicating.
So Ryan, there are some changes in calaim that have nothing to do with managed care, that have, as we heard from Michelle, have impacted the county behavioral health directors a lot. Can you talk a little bit about what those have been like and what they involve?
Sure. Michelle did a great job of hitting policy level, high level. So I'm trying not to be repetitive and hit on the exact same explanations that she gave. But I'll just run through them really rapidly. First of all, payment reform, as you heard, we're all struggling with these timelines, acknowledging that these are difficult timelines to have this all up and going by July 1st. Our budget is due February 17th, and I have not yet received all of my rates. So that's a challenging situation. So that's a little boots on the ground. In terms of going through the no wrong door, this one was extremely helpful because we're now able to help people out before we have this completed assessment and diagnosis. So we're able to bill Medi-Cal while we're helping people get to where they need to be, whether that's into our plan or whether that's into a managed care plan. And so we don't feel like we're having to, we never would say no. We would say, let's hurry up and get you where you need to be so that, we could go back to our billing activities. I'm exaggerating a little bit, but, now there are all our billing activities. And so that's a really great plus there. SMI SUD integration is going to be great because this is one of my favorite. This is one of my soapboxes because right now there are disincentives for mental health providers to provide SUD care through the SUD system because you'd have to have a second contract. You'd have to have a second set of billing mechanisms, a separate cost report, I could go on and on, separate grievances, separate it's just ridiculous. So the idea behind integrating is let's just have one contract so that once you hit one of the requirements, you're also hitting the other requirements. Jail in-reach services we're extremely excited about. It's on the ground experience there is, have to remember, these are jails. This is not my house. This is the sheriff's house. And they have extremely limited room. So if we already have their existing health workers that are providing care within the jail, we already have their existing behavioral health folks in the jail. The idea about having other providers from outside doing the jail in-reach is adding to the demands on the sheriff and their resources in terms of being able to transport inmates to wherever they need to be in order to access those services, as well as it puts space constraints in already very constrained environments. So those are some of the boots on the road. The other one I have to say thank you to our managed care plans regarding another initiative that Michelle didn't get a chance to get to was our school behavioral health incentive program, where we're working very closely with all of our various school districts within Sacramento County, and actually working very closely with our main partner, Sacramento County Office of Education, to come up with a county-wide strategy and plan around how to get behavioral health into our schools, and working very closely with our managed care plans to come up with one plan for all managed care plans and all school districts.
And as we heard about earlier today, just over a week ago, we found out about the approval of pre-release coverage. Shamsher, you've been working on reentry for people who are just involved for many years, but can you talk about how you think the new policy might change things?
Yeah, no, I think like many other folks have said today, I think there's tremendous promise. Very optimistic about the vision and what's possible in that 90-day pre-release work. And I think it has an opportunity to do a few things. I think one is, start to shift some of these structural challenges that we experience in whole person care. For instance, we can have case managers, we can have community health workers who are engaging folks pre-release and work with them longitudinally. But, it was limited in its scope. And then, there's the challenges on the community-based side where, folks are still engaging with clinics who might, give the person an hour to kind of land in that clinic. And if they don't make it, their appointments get canceled, and it doesn't really accommodate for all that vulnerability. So in all, shifting that frame on the community-based side to understand some of those vulnerabilities is critical to this. On the pre-release side, we know that at least we're anticipating in LA County, we're going from serving up to like 600, 700 people a month, all the way up to potentially 70 to 80% of LA County jails. And just for context, I think there's something like 60 to 70,000 releases from jail in the recent year. So a huge number of folks are potentially going to be eligible for services. And in addition to the case management services that we had previously, we also have the opportunity to potentially reimburse for things that help reorient our system, our clinical systems towards reentry. So, using the example of someone who maybe has a chronic medical condition, either an in-reach provider, or our case more likely an embedded care provider, can now get reimbursement to be in touch with a community-based provider. And that was the piece that was kind of missing under whole person care, right? It was, you had the case management, but then the clinical pieces are limited in correctional health settings. And now there's an opportunity to kind of add in that additional element, which is critical not only for chronic medical issues, but also individuals with behavioral health issues with serious mental illness. And this is, especially when we tie it in with this expectation about behavioral health warm handoffs, where there's an expectation that a behavioral health warm handoff happens within, a few weeks or a week or two of release, and suddenly you're having big kind of structural changes in how folks are being engaged. So we're still working through a lot of those processes and kind of thinking about, there's a lot of challenges. Correctional health settings are places that have historically built. To your point, Ryan, the idea of how you accommodate folks coming into facilities that are locked with security, that have their own potential health systems, are all very complex. And, they're still, that's why I say that there's a lot of promise, but, seeing it through is going to be the next step in this work.
One of the hallmarks of calaim has been a significant amount of money flowing for implementation. So there are incentive funds that flow through the plans that Anwar talked about, IPP, as well as funds that providers can apply for directly through an initiative known as PATH. Would love to hear from the panel about how you've used those different funding streams, how they differ, how they're helping.
Yeah, we work very collaboratively with one of our MCPs that really allowed us to use the IPP funds to increase capacity. We, as part of getting credentialed and approved for the contracts, we had to submit capacity reports as to how many clients we could actually take in for any of the community supports and also ECM. And as part of that, we were able to work very closely in applying for some of those funds, and there were milestones, we had to meet along the way, but it really did allow us to be ready to take on those increased numbers that came in. The first quarter, we were hiring staff, training them, but right after that, we were able to take on a lot more folks who really needed the services because we were able to hire up and train. So we're thankful for that. And there was some overlap between the IPP funds and then the PATH funding as well. So we're working through some of that and really looking at ways on how we can look at funding that can continue to expand our care services. But there was some confusion as to what IPP funds are for and what PATH funding is for. So just trying to make sure that we're clear on what we're asking for, as we apply for that.
So for partners, we were able to kind of separate the IPP funding and the PATH funding for different purposes. The IPP was mainly, just like Pooja, was for capacity building. We built our health information exchange platform through Salesforce. And we were able to bring up a workforce development and have a curriculum that would onboard and train all ECM and community supports, care management and navigators, not only for our agency, but those that are subcontracted with us, the other CBOs. So it's really mainly used for program implementation. Now, for PATH, it was slightly different. We use that to really focus on an integrated care coordination approach. How do we enhance care management? And our way of enhancing that is to really work with other providers, bring in the medical groups, the hospitals, the FQHCs, and any other CBO that really works, like the housing service providers, so that we're all working, even though we're care managing, we're all coordinating and exchanging the information so that we can all help to make sure that we make a huge impact in our community.
I have to admit, IPP and PATH is quite a confusing sort of set of different initiatives that I don't want to misspeak, but if I'm remembering right, for IPP, some of the low-hanging fruit where we got some funds, as I just mentioned, the challenges around startup funding for our contract providers. So we did apply for some startup funding for those providers. It's not exactly the best timing, but I think it will ultimately end up helping out our providers to some extent. We also worked on some funding that would be specifically, okay, so my providers are behavioral health providers, right? They're not physical healthcare providers, and we're asking them to stretch into the physical healthcare realm in doing this enhanced care management thing. And so in order to help them do that stretch, we went out to find a consultant to help develop some technical assistance. That's probably not quite the right word, but just some materials to help our contract providers with training their enhanced care management folks, rather than expecting somebody who has a behavioral health very strong behavioral health leadership background to be able to help bring their team along in the physical healthcare realm. We wanted to develop some materials for them. So that's one area that we also worked on. Another area was we're working on doing sort of a needs assessment regarding community supports to see if there's other areas where we as the county might be able to help facilitate, develop additional resources or whatever it might be that we might need to help promote within the county to help further strengthen the community supports that are there or honestly might not be there. So just doing a little bit of a needs assessment around that. And then finally, and this is the one I think is IPP, maybe it's path 2, I can't remember. We're putting together a social health information exchange for countywide data that will be able to help us track our individuals receiving services across a number of different agencies. And so we're very excited about that as well.
Yeah, from LA County side, when it comes to system impacted folks, the PATH funding is predominantly, or at least one stream of the PATH funding has gone to this whole process of Medi-Cal suspension and unsuspension. Folks may be familiar with this, but that in and of itself is extremely complicated, just given how many folks are moving through jail systems, unfortunately, the unpredictability of releases. But then you add on top of that the fact that this is going to be very closely intertwined with our 90-day pre-release billing. So now you have this added element of you're trying to get everybody on Medi-Cal, you're trying to suspend it at a certain time, unsuspend it at a certain time. Then you have to approximate when someone's going to be released, like 90 days pre-release, which is, especially on the jail side, but maybe on the prison side as well, it's extremely complicated as well. And that becomes important because that 90-day pre-release marker and getting a particular aid code is what's going to allow those billable services that I was talking about earlier. So some of the PATH funding has gone towards starting to think through how that's going to work. And then some of it's going towards sustaining and helping bridge our whole person care programs in the sphere to calaim.
And one of the other things just around the IPP, I'm recalling, we were very surprised by the volume of referrals we got for housing navigation. We were expecting a lot more activity on the ECM and the recuperative care side of it. And one of the health plans was asking us if we could take like 50 referrals a week. We were not ready for that. So when we were able to get the IPP funding, it did allow us to hire more staff. In fact, we had to open a new office space in that county. That team went from like 6 housing navigators to 15. So, it did help having that, available resource to be able to train some of our internal staff who were case managers, who knew the world of housing navigation, get them ready and have them be able to meet the need, because we were not anticipating, I think in that particular county, we have like 1,100 clients on housing navigation now. That was something that was totally unanticipated for us.
One last question before we turn it over to the audience. What else is on your mind as we head into the second full year of calaim implementation?
I'll go. A lot of things are in my mind for calaim. It's such an important program. And never in my whole life, as a young care manager, climbing up, working in other nonprofits, I've never ever seen such a huge effort. So my job is to make sure that it's successful. I'm really excited about the enthusiasm that the managed care health plans have to make it successful, as well as the Department of Healthcare Services. So fine tuning the program, as I mentioned in the beginning, is important. Sharing best practices, specifically with the new PATH collaboratives, super important. And really that data integration that I keep talking about, so that we all know what we're doing, so we can measure the efficacy of the program, because how else are we going to know if it's successful? And also, looking at other programs beyond calaim. Partners in Care is one of the largest Medicaid waiver service providers for the State Department of Healthcare Services. So we have all these other programs, and we have brought them to the managed care health plans before, so that we can begin care coordinating. But how do we lift those programs so that we are able to look at them and braid them and weave them into a continuum of what happens after ECM when people graduate from ECM? Do they go into the multipurpose senior service program or the HCBA waiver program, assisted living facility, things like that? So that's what's on my mind.
Yeah, I feel, for our population, it has been transformational. It was hard for us as a community-based organization to fit into this calaim box, but it really did allow us to expand more services to this population. I really am hoping that this coming year, we can truly look at the criteria for recuperative care, where most of our clients really need these services, to standardize it, because there are some clients who really need this service and aren't able to get it because of the way each MCP is running this program. And at the end of the day, I'm really looking for outcomes. You know, I'm hoping to see what the MCPs are going to be reporting in terms of the outcomes for these clients when it comes to quality care and cost. We're definitely seeing lives change for our patients, you know, who really benefited from these services. And I sort of want to see some data on that, you know, how that's looking overall for everybody.
So what else is on my mind? I'm going to go in two directions. One, first of all, I think I'm going to put on my hat as president of County Behavioral Health Directors Association and just sort of, not necessarily Sacramento, but as a state as a whole. This is a lot. There are a lot of behavioral health initiatives going on right now. And it seems like every day I come to work, I'm hearing about another one. And so just sort of recognizing that this is a lot we're putting on our agenda, and they're exciting initiatives. There's not one that I want to say no to. Right? We want to say yes to it all, but it is a lot all at the same time. I am concerned around supporting our rural counties and making sure they don't get left behind in some of these initiatives. There is another initiative that we haven't even talked about yet, the mobile crisis benefit that DHCS is, and it's required to be 24/7. Think about being in a rural county where you have to have a team. So it has to be at least 2 people that are working 24/7. And during the course of a week, you get what, 8 calls? That's an expensive program. And there's sort of a thought process, well, we can regionalize it. Well, these counties, rural counties, they are really spread out. How do you have a regional model where somebody responding from the west side of the state is going to get to the east side of the state in enough time to be able to actually be responsive to that need? So we have some serious things that we need to make sure in all these initiatives that we're not leaving any of our counties behind, and making sure that we're being supportive as possible and being successful as possible.
Yeah, I would say, thinking about what kind of got us into this situation, or what allowed kind of the last several decades of reliance on carceral systems and divestment in community-based systems of care that we're trying to kind of right the ship now. And it's obviously a lot of factors, but in my mind, one of them is, accountability to the communities and individuals who are impacted by these systems. So as we're kind of moving towards calaim and we're trying to build these new community-based systems of care, how do we ensure that not only are folks who are impacted, their families employed in these programs, but the programs are actually accountable to those communities, whether it's community advisory boards or, genuine positions of accountability. Because I think if we don't think through that, we run the risk of, despite kind of our best intentions, building things that aren't always at the, best service of communities.
What questions do you have for this fantastic panel?
Hi, I'm Tracy Rattray from the Public Health Institute, and I want to thank everyone on the panel for the incredible work you're doing to get calaim off the ground. I mean, I can see that is a huge, huge endeavor. And yet, I don't think the new focus of calaim on the social determinants of health is enough to truly advance health equity and to truly contain healthcare costs. To do that, we really need to focus more upstream on community-based prevention. And there's lots of examples. If we invested more heavily in ACEs prevention, we would reduce the number of people who are incarcerated in the first place. It's proven that tobacco policies that really target communities of color work, and they have worked, and we've seen tobacco interventions. And so I would love to hear the panel's thoughts on the idea of complementing this new focus of calaim on the social determinants of health with investments in community-based prevention. Thank you.
I guess one of the things, that's gonna be an ongoing challenge is how do we move folks into housing, right? This population that we're all working with, and there's these great benefits, enhanced care management and short-term post-hospitalization. The lack of housing is gonna be an ongoing barrier for us to move the needle, and we need those agencies to partner with DHCS and really look at some innovative solutions together. Because at the end of the day, we are going to be providing services that are time limited. A lot of these calaim benefits, it's 6 months, 90 days. What happens afterwards? If we're not able to move folks along the continuum, and that's what we do at Illumination Foundation, housing and healthcare. So we need both to align for us to move things forward. And if we're thinking upstream, we have more people falling into homelessness right now than, coming out of homelessness. So we need to look at that system-wide and partner on that.
I'll add to that. Part of our services is really based on a person's doing the in-person visit and assessment in the person's home. We believe health begins at home. And for those that don't have a home, we go to them and we do that comprehensive psychosocial evaluation that does capture the social drivers of health and also the medical needs. And that's really our main focus. We don't really rely on self-reported data. We actually go there and collect that data. It's different than bringing a brown bag of medications. It's really going through what kind of medications you have in your cabinet, and are they from Canada or Mexico, or what kind of vitamins contradict your medicine. So that's our strategy: home-based or in-person, away from the clinics, away from the medical setting, so we can really capture some true social data.
I'd say,
No, go ahead.
really quick, I'd say in behavioral health, we already have quite a history in terms of being able to develop community-based supports that try to focus on inequities. We, in Sacramento County, we have what we call our supporting community connection programs. It's about 10 different providers that are all embedded within culturally diverse communities in order to reach out to those culturally diverse communities. For example, La Familia would be our Spanish-speaking population. We have the LGBTQ Center. We have an organization, I'm going to blank on their names now, that works with the Russian-speaking population and so forth. So, and we still have more work to do. We still see inequities. We still need to keep on focusing on that. I could keep going with the list of things what we're doing, but just want to acknowledge that the data tells us we're still not there. The other thing I want to point out in terms of inequities is that we still see housing policies that are not equitable for behavioral health consumers. People, and they are not able to get into housing. Sometimes we still have landlords doing credit checks for somebody who's homeless. This is ridiculous. Things like that just continue to put impediments. Another thing I want to point out is permanent supportive housing is not for everybody. We have behavioral health consumers that will never be able to qualify to work, to live in behavioral health and in permanent supportive housing. So we need things like board and cares and other living situations that will be supportive to our behavioral health consumers.
It's very briefly. I mean, the question really does resonate. I think in the reentry space, as we transitioned to calaim, we had a network of reentry providers, some of which had more of a orientation towards accompaniment, social services, political, and some of those agencies didn't make the transition over to ECM providers, just given the focus was incompatible, the requirements. And obviously, that's kind of a loss. So at early stages, what we're thinking through, how are there ways like regional models, for instance, or other ways where we can layer on some of the orientation of calaim and preserve some of that value and that history of service in those agencies, but definitely something that we're working through still.
Hi, my name is Sage Wolf. I'm the Director of Integrated Health for Redwood Community Services. We're a nonprofit organization who is rolling out ECM and community supports for Mendocino County, Lake County, and hopefully Humboldt County. So very rural communities really struggling with implementation and capacity really being the big thing. So I really appreciate what you guys have shared on the panel today. This may seem like a silly little nuts and bolts question, but it's one that I've really been struggling with, and hopefully maybe you can give some perspective or like just a little tips. We're struggling to figure out like kind of a manageable caseload size for our providers, and specifically working with the unhoused population. We're rolling out right now with that being our target population out of our emergency shelter and homeless resource center. And what we had mapped out like a kind of the fiscal picture of what a caseload could look like to support both the position and like the outreach services and all of the pieces that are needed. And the caseload size, what we're finding, and we knew this beforehand, is that it doesn't feel doable. It feels very insane to us to have such a large caseload for a population that this isn't just enhanced care management where we're just coordinating their services that they have with other providers or that they're getting services elsewhere. This is a population that is really not connected to other providers. They're falling through the cracks and disconnected and very untrusting, and there's a lot of stigma and yada yada. And we're finding that when we have what we thought would be like the fiscally responsible, like to make it fiscally manageable caseload, it is terrible for our providers to actually realistically do work. Do you have any recommendations on caseload size and how you've been able to make it for both housing navigators and the ECM provider? Thank you.
So to repeat the question, manageable caseload recommendations for people who are unhoused.
Absolutely, and I could even give you a copy of our budget. If you want, in the end, we've worked really hard with this, and we have those multiple waiver programs, so we really know that the caseloads are very important. So there's kind of three things. For enhanced care management, we have a 50-to-1 ratio, but I know it's pretty tough, but here's the key though. With enhanced care management is a long-term care management program. And the community supports program is kind of a care management that's hyper-focused on housing services, and it's care management on steroids. So now we dually enroll them in both programs, and now they are working so that the ECM care manager is really working on all the other social drivers and medical coordination, while this one is just the community supports is just hyper-focused on housing. But we don't just stop there. We hold the housing service providers responsible for some of our care plan findings too. So, hey, we got 5 care plan findings. You're going to take this on yourself because you're responsible for that, even with the PCPs. So we kind of start, in a way, unofficially delegating some of our care plan findings to some of the other medical providers in order to put them in a spot where they have to step up and help.
Yeah, same here for ECM. Again, we're doing it in one county and it's 50-to-1, but the key is you got to leverage the other benefit like housing navigation. Bring them into recuperative care. If you're not able to manage anything else that's going on, you got to bring them in, get them approved so you can start working on things, because there's no way you're going to be able to address all those things. So enroll them into ECM and then leverage some of the other benefits like housing navigation. And once you get them into housing, they continue to be in housing retention. And on the flip side, where we're not doing ECM, we have to work really, really hard to get them enrolled into ECM. Yes. So the caseload is 50-to-1, but you have a team that's working on, complementing those services. And that involves a lot of coordination, case conferencing on a weekly basis. And it's not easy, but it takes a while for the care manager to really look at that care plan and prioritize which clients you're going to focus on for these things. And you're not going to be able to do everything for every single client.
So for behavioral health, I think this is one area where the strategy about working with our existing service provider is helpful. I will not pretend like we have it figured out yet. As I mentioned, we're just getting some of our first authorizations, and our providers are just getting up and going. So, but I do think, so it is 51, but I do think that by partnering at the same physical locations as well as with the same team of providers that are also providing their outpatient mental health services, that's another area where there's some support. So it's not one person doing it all.
I don't really have anything to add into this.
My name is Graciela from Altura Centers for Health in Tulare. We're in Tulare County, Central California. We're at FQHC, Federally Qualified Health Center. Mine is more of a comment. I feel like our health plans need to be more inclusive. We're a 2-plan model. We went live with HealthNet last year, but Anthem denied our application, said they had enough adult providers. So I feel they should be more inclusive, especially because we have over 22,000 Medi-Cal lives, and I feel that they're better taken care of at our center than somewhere else.
Thanks for sharing.
Thank you. I'm Michael Cousineau, member of the Hospital Commission in LA County. One of the things our commission has been hearing a lot, particularly from the enhanced care manager providers, is we have more case management, but on the other side of that, we haven't necessarily expanded services, particularly for mental health and people with substance abuse disorders. And I'm wondering whether or not we have invested enough. We're investing a lot in care management, it's great. But have we invested enough on the other side, looking at payment reform, looking at expansion of payment for physicians, for the mental health providers, so that these care managers actually have some place to refer people to? And that's my concern about the future of calaim.
So the question is, in addition to investing in care coordination and care management, are we seeing a kind of concomitant investment in basic services?
So I guess that's me. Behavioral health, we're primarily funded by our 1991 realignment and 2011 realignment and the MHSA. The two realignment pots, the year tells it all. That's where they're stuck. So in 1991 realignment, that used to be able to run an entire system. Now, I'm telling on myself a little bit, but that's okay. It just covers my inpatient bills. So this is our infrastructure around and payment for behavioral health services has not kept up with the times. We need to continue to make sure that we're investing if we want to continue to meet the needs of our community. The other part I'll say is, so in any other healthcare profession, you would see specialty health, the specialty fields would make more than their non-specialty partners. You can call me a liar if I am, but I think that's probably true. In behavioral health, county is specialty mental health services. Our specialty mental health services are not being reimbursed at the rates that allow us to be able to pay more than what clinicians are able to make in other private environments. That is it's unbalanced.
I'll just add, yeah, I think that's an accurate assessment. I mean, some of this work is, trying to set up, primary. When I formerly worked with the reentry program and was it kind of working in the jails and trying to set up primary care appointments for folks and the safety net or behavioral health appointments. And, it's this extended wait time, right? We're going to give somebody 30-day medication and they're going to do case management, but then the appointment's so many days out and the behavioral health appointment maybe doesn't happen. We know for people with serious mental illness, they're primarily engaging crisis services, not kind of preventative services. And in some ways, the structural historical tendencies that, acute care services is where many of these folks are going to engage. And I think, we're not quite there yet. It's my gut sense.
Hi, excuse me. So this question stemmed from Ryan, your comment regarding your interaction with school districts. So it is a behavioral health related question, but certainly, it's open to the entire panel, of course. From I'm sorry, my name is Tony Amato. I'm a special investigator for the California Department of Managed Healthcare. And so from my experience, it becomes very complicated trying to determine like jurisdiction for when a child needs behavioral health care. Like let's just say, for example, a child needs long-term residential treatment. It gets complicated whether or not it's the health plan's responsibility or it's the school district's responsibility. We don't have to really go into that right now, but my specific question is, does the implementation of calaim alter or, better yet, just affect the current, interaction between state and county health, health plan and school district? Does that make sense?
Maybe, let me try. So I'll say the one area where we're definitely seeing improvements is around the no wrong door policy.
Yeah.
Where existing, prior policy would have made it very difficult for us to be able to hand off youth to managed care plan, because we're not getting billed for, we can't claim for the time spent doing that. So now we're able to claim for that time. So we're going to be able to serve them and give them what they need while we're working on connecting them with their managed care plan, if that's the level of care that's most appropriate. Or if they need to stay with the county, then we're able to continue to serve them while we're working on doing that assessment. So that's one area where I think we have seen some good improvement. Did I answer you? Good. All right. Good.
Good afternoon, Eva Terrazas with Pacific Clinics. My question is to Ryan. You spoke a little bit about the reimbursement rate for behavioral health. One of the concerns that we have is that the massive infusion of billions of dollars in behavioral health over the next couple of years is just astronomical. But what happens after that? When we scale up, when we get the workforce, when we're delivering services, and after the governor's budget, the 5-year plan is over, you don't have that investment in either housing or behavioral health. And how do we sustain kind of equity, right? And how do we even sustain the whole financing structure of healthcare?
I couldn't have said it better myself. It's wonderful that we have all these funds going to behavioral health, but it's also going to be a challenge because they're all one-time funds. So we can look at behavioral health bridge, see all these names I have to remember. Behavioral health bridge housing project, once again, short-term, one-time funds. So then what do we do after we build up that capacity? Another one, so don't get me wrong, I'm thankful on all these, but behavioral health continuing infrastructure program, this was the $2.2 billion for the acquisition, renovation, construction of behavioral health facilities to expand bed capacity throughout the state. Very fortunate if Marlise or any of her folks are in the room for helping award us 2 grants under this. We were funded for a $28.5 million 64-bed mental health rehabilitation center, which is a subacute step-down facility to help get people out of inpatient care. And then our second facility was a youth crisis, I'm calling it youth crisis facility. It includes a 16-bed youth psychiatric health facility and a crisis stabilization unit for capacity for up to 27 youth at any given time. These are awesome new resources that are coming to Sacramento County. The funding does not pay to operate them. So full stop, right? So now we get to figure out that part. I mean, of course, I have a strategy to do that, but that is a gap that we as the county are having to figure out and meet.
Hi, my name is Abraham Husseini, and I serve at a rural FQHC in Central California. At the FQHC level, we have been struggling with following up with many of the marginalized community members that we serve, simply because of the sheer volume of patients we have and the lack of specialists in our areas. Often we do not have the services and agencies larger counties like Sacramento has. With respect to calaim initiatives, any advice for us smaller rural counties in streamlining our referral processes? In particular, maybe coordinating referrals.
I'll try to take this. The only advice I could really think of is working with your managed care health plans, trying to get some IPP funding or PATH funding to kind of straighten your referral base and really build your strategies, whether it be through system integration or even just people or telehealth. If you can't reach them, then reach them at least with telehealth. But somehow come up with a strategy and have the and take advantage of the IPP or PATH funding to kind of build that proactively so that you can onboard your team or bring in your system so that you have a strategy and not necessarily have to wait to scale that up because you could pre-scale it. So yeah.
Thank you.
Thank you. I'm Joe Garbanzos and representing AARP. Thank you, panelists. I think you live up to the expectation as far as the theme, which is local perspective, very granular stuff. Thank you very much. My question is a little bit more perhaps strategic. It's in the context of a demographic shift where we expect that aging population will increase faster than the rate of increase of 18 years old and younger. So the question is, calaim, how does it relate to the master plan for aging? And perhaps the more specific question is what you're doing individually. What can you anticipate to give advice to organizations like ARP to be in the lookout for the senior population that we expect to be increasing? Thank you.
So the question is, how does calaim intersect with the master plan for aging? And then how are each of you thinking about preparing for addressing the needs of older clients?
I think the key thing is making sure that, clients get enrolled into these benefits. It's hard to get everybody qualified, but also building services that work towards their needs. For instance, we're working on an intergenerational program that's really gonna serve the senior population to make sure, that we bring them into programming early on, but then having, locations that's really gonna serve, to their needs. But most importantly, what can we do to get them enrolled in services? A lot of it is requiring the appropriate paperwork, documentation, and really making that case to the health plan to get them approved.
One of our strategies is really to be proactive in working with the community that we're serving, informing them about all these other services that are available for them. It's kind of a outreach and engagement all about home and community-based services. That includes calaim, but there's much more other services that are out there. So how can we educate the community and try to pre-enroll the people that we kind of expect will need the services in the future? And that's not only us on our own, again, going back to collaboration with other medical and community-based providers so that we could outreach even within our own ECM younger population that we're serving. We notice that they have grandparents at the house and kind of do that type of outreach. It's kind of working on a whole spectrum of care. I think you mentioned that too. So working from that point of view, but also getting involved with the master plan at the state level and really helping connect calaim, the MLTSS that's coming up as well with the master plan. How do we kind of blend all these? And to answer your question, I don't think there's a really solid explanation how they all interlink, but working at the state level with our friends at the managed care health plans and the Department of Healthcare Services, that's kind of what we're doing now to kind of help change that policy or shift that policy.
I think that was well said. I'm going to add one comment to it, and that is that one of our current and ongoing needs that will become more and more of a need is treatment beds that are able to support people with co-occurring physical health care and complex disease type circumstances, which is a place where we see a huge problem right now. If somebody has something more than just a mental health challenge going on, it's really difficult to find them a mental health bed in any level of care. So that's something we as a state are going to need to continue to think about and identify strategies to address.
And just to echo that last point I think there's kind of maybe a stereotype or misconception for folks who are affected by the carceral system as being young and healthy. And we know that that's not the case, but in the prison side of population, folks coming home, definitely there's an elder population. more so, in the jail population as well. And especially for folks that may have limited family support or may have need assistance with their care needs, having those types of beds available that are willing to take folks who are coming back from carceral institutions, address behavioral health and physical health conditions is key. And just the complexity of, having providers in this ECM world who, it's one thing to say that, we're able to serve the justice involved population, but recognizing that, there's tremendous kind of nuance and needs within that.
Thanks so much. That's all we have time for today. Let's give a round of applause for our amazing panel.
Well, thank you so much, Melora, and all of our panelists on this panel and our previous panel. This was, in my mind, the best of ITUP in that we got so many diverse perspectives. We went everywhere from those very big picture, what about trust, what about relationships, what about the policy construct, to the very granular, how do I do this? How do I make it work? What are the things that are getting in my way right now? And it is a great testament to everybody who participated in our work groups this last year, who provided their perspectives, to our panelists, most of whom I think were among those folks, many of you in the audience. And then the questions today too were just fantastic in bringing in additional perspectives. So thank you to everybody for being here. Again, I want to really acknowledge just the annual work of those work groups and the opportunity that gives for cross-fertilization and for conversations, both across different geographic areas and different sectors, and so important in the context of CalAIM. So we always, yes. We're going the right way. Oh, good. We always appreciate your feedback. And we will tell you many times that we would really greatly appreciate you filling out your evaluation forms. There's a code on this, and I think it's available through the app that hopefully you figured out how to download by now. But if you have questions, folks at the ITUP information desk can help you. Before we let you go from this formal part of the pre-conference, I want to highlight the Spirit of ITUP annual networking dinner, which will occur across at the Sheraton beginning at 5:45. We hope you plan to join us to celebrate this great time of networking and being together. We do not have a big agenda, but we do have a couple of special ITUP announcements to make that we hope you'll join us for. And if you happen not to have registered for the dinner but want to join, never fear, there are opportunities to add that to your registration. So see our great team in the lobby. And then, of course, we hope everybody will be back tomorrow for our full day's agenda, which is just full, I think, of timely topics and wonderful speakers. So again, please join me in thanking this panel, all of our panelists today, and we'll see you again very soon.